I do an additional what we call thermography sequence, which is where we measure the temperature in the gland. And what we're really looking for is not the temperature, we're looking for susceptibility artifacts during the temperature acquisition. In other words, are we going to lose temperature certainty?
Yeah.
We're allowed to do that on parts of the gland, but you don't want temperature uncertainty where you're treating the cancer.
No, of course.
So you have to relate all these together. And then also, since a lot of my patients don't have a CT scan, well, even if they have a CT scan, even if they have calcifications, I still do a three-dimensional SWI sequence.
So susceptibility.
And I'm looking, now granted those calcifications are bloomed, but it allows me to do a susceptibility image on the day of treatment while we're treating the patient so that I can move the applicators in relationship to where the calcifications are sitting.
So you deposit the energy just above or below the calcification.
Correct. Change the angle of the transducers. In other words, the UA, the applicators, the 14 megahertz or the 4 megahertz, we can actually change the angle that it's shooting at the calcifications. And we find that very important. We can also make decisions about should we boost the rectum to change the angle. So there are a lot of decisions you have to make with calcifications. The other thing I do, besides the SWI image, I also acquire a three-dimensional a 3D T1 space fat saturation, because then I am comparing what is blood versus what's calcification. And the calcifications are going to be dark on T1 and dark on T2, whereas if it's bright on one and dark on the other, then that's blood, and I'm not going to worry about that, because blood causes susceptibility artifacts.
So that's how you
it messes up the SWI. It's how I separate the changes on the SWI. So I'm doing a 3D T1, I'm doing a 3D T2, I'm doing a 3D SWI, and all these sequences help me prepare the day before of where I'm going to set my treatment plan. I don't just take the images that come in on the patient and decide I'm going to do a TULSA.